Thank you for your statement, Cabinet Secretary. No one in the Chamber would disagree with the overarching principles of your plan, which include improving patient experience whilst keeping the costs of care to a reasonable level. And in this respect, the 1,000 Lives Improvement to help Welsh Government and NHS Wales establish sustainable services and improve patient experience in planned care specialities is welcome. Indeed, the Wales Public Services 2025 programme, hosted by Cardiff Business School, has put the choices in Wales into sharper relief in its recent report, when it states that under certain assumptions, 56% of the budget could go into the Welsh NHS by 2021, and the percentage might be even greater in subsequent years. So therefore, we do have an issue here where we put more money in and we're not achieving our targets. So I wonder if you could make a comment on that, please, Cabinet Secretary. The term patient experience covers a number of areas, which include both patient outcomes and patient waiting times. As you have stated in answers to my questions last January, we need to balance the reduction of waiting times with the quality of interventions and outcomes that patients receive in Wales. So how do you, as Cabinet Secretary, plan to do this? I welcome the news in your statement concerning the redesign of the prostate cancer pathway across Wales, having heard from many constituents in my region about the difficulties of previous treatments that were around before the pathway. Similarly, the rollout of one-stop clinics mentioned in your statement is also to be welcomed. Also, the intention of the programme to develop patient-reported experience measures, PREMs, and patient-reported outcome measures, PROMs, to capture and analyse patient experiences of services along elected pathways. However, I'd like to ask Cabinet Secretary the extent to which community health councils will be involved in the capturing of patient experiences. If they are not sufficiently involved, then we may run the risk of having two separate records of patient experiences, one in the PREMs and PROMs reports and the other via community health councils. Would it be far better if patient experiences recorded via each of these avenues were put together? And in order to gain the most lucid picture of patient experiences. I welcome a holistic approach to patient care and lifestyle modification, and I would ask what up-to-date advice and research from other groups will be incorporated into the holistic approach and lifestyle modifications. Previous documents concerning the care programme mention that one of the aims is to reduce variation across Wales. For example, such an aim may result in reducing the number of follow-up appointments that are offered following surgery, as this may be an accepted practice in other UK health services. Whilst being broadly supportive of the overarching aim of ensuring that NHS Wales costs are kept at reasonable levels, I must emphasise, Cabinet Secretary, that every case is different. Sometimes a variation in services and appointments to treat the same or similar conditions, maybe in different areas also, is absolutely necessary. So there needs to be room for sufficient flexibility within the programme. The evidence of 9% of people not attending follow-up appointments mentioned in your statement is disturbing, but every case is different, and we must not seek to reduce follow-up appointments across the board if such a practice does not produce optimal results for the patient. The evidence that your statement cites from an Iron Bevan Health University Health Board, which has the potential to reduce unnecessary appointments across Wales is welcomed, provided that we can ensure that such appointments are genuinely unnecessary. That is to say that they are routine cases without complications or exceptions. Therefore, Cabinet Secretary, could you ensure that health boards have clear guidance on what constitutes exceptional circumstances in a given case? And moreover, when a case is deemed exceptional, please could you ensure that health boards have clear guidance concerning what further resourcing would be considered permissible or best practice? I note that your statement says that there has been a reduction in the number of non-urgent suspected cancer patients. However, I have mentioned in the past that when someone is given a cancer diagnosis, and diagnosis is of the utmost urgency for them, we need to ensure that they have best patient outcomes, and when a person is told that they possibly have cancer, that we treat all of this as urgent, because to that person, the word cancer means that something is going on that needs urgent treatment. Finally, I understand that the planned care programme currently focuses upon 4 surgical specialities: ophthalmology, ENT, orthopaedics and neurology. I have read in your statement since that there are more in the pipeline. So without wishing to run before we can walk, I would like to ask whether there are any long-term plans for the programme to apply to other surgical specialities or other areas within the NHS Wales. And if so, what methods would be used to evaluate the effectiveness of the programme upon the initial 4 surgical specialities? Thank you very much.
Cabinet Secretary.
Thank you, Presiding Officer. In responding to the questions and the points made, I'll start by repeating and then adding a little to some of the points that I made earlier about finances and the reality of services. As you're right, our current projections show that we'll spend comfortably more than half of the Welsh Government budget on the health service in the medium-term future. That is because of the choice this government is making, on the one hand, to prioritise the health service, to make sure that frontline services are funded, and that we have a generally sustainable system. We're not doing this simply on the basis of our long-standing political commitment to the service, but because of the objective ends we've taken both from Nuffield and then the Health Foundation, with the gap that needs to be met to keep the service sustainable. That includes not just more money going in, it includes continuing efficiency gains being made year on year within our service. And the risk to that also is staff. It requires a continuing element of wage restraint, otherwise the service is not affordable. And there we come back to both the pay cap and a UK government decision on whether they are prepared to be serious about the pay cap. And I notice they've recently confirmed they're going to put off putting evidence in for the pay review bodies. It means that our public service workers who are expecting the reviews to take place won't know what the position is till much later in the year. And any pay rise of any level is likely to be delayed as a result. That may produce a saving to the Treasury, but I think puts more pressure on our hard-pressed staff. And it goes back to the central choice about austerity. The financial lead for the WLJ, Anthony Hunt, this weekend made the point: Tory austerity pits public services against public services. If it doesn't end, it will have catastrophic results for communities up and down the country. On our challenge here within the service on reducing waiting times and making sure the trade-off in quality, I recognise what you say about how we try and measure, how we get an understanding of what the patient experience is. And it isn't just PREMS and PROMS versus the CHC movement. It's just about understanding where is a differing role for different parts of our system. I think PREMS and PROMS could and should be really useful in understanding people's experience and proactively asking people what matters to them, then designing services about what patients tell us, but equally about understanding there's more than one place to go and get this. So it's in the numbers that we have, but it's also in the clinical audit work that takes place as well. There's rich areas for improvement there as well, and that benchmarks us across other parts of the UK system. In each of the implementation groups, you have major conditions. The third sector are always involved within that, so you have an area of challenge from those groups who are acting, if you like, as the voice of the patient within those services as well. And a good example of where a third sector group help us to understand the patient voice is in the Macmillan survey we just had, telling us about cancer services and the direct patient input. So we understand from a variety of sources what patients are trying to tell us about services they value and how they want to see them improved. And in trying to make those more consistent or complementary, we should not choke off different areas to understand what people tell us. And your points about follow-up, I think I've broadly dealt with. I'm pleased you recognise that ENT appointments in Iron Bevan have reduced by 40%. The challenge is, as Angela Burns is asking, how we make sure that follow-ups are clinically appropriate and we don't drive unhelpful demand into our system that is of no value either to the clinician or to the citizen. And I don't think there's a great level of reassurance to ask to be told to come to a hospital site for a follow-up appointment with a consultant. If you then wait for a period of time, you have to try and park somewhere, go along, take a significant part of your day, and if you then have 5 minutes of time with a clinician who says, everything's fine, thank you very much, that isn't a great use of that consultant's time, and it often isn't a great use of the citizen's time either. So there's much more efficiency that we could get by actually, in a clinically appropriate manner, changing the way the follow-ups happen and who people actually go to see. And on your other points about other areas for the planned care programme, well, that comes down to the advice we'll get about the right number of areas, but also the capacity of our system to make a real difference in these high-volume areas of activity. And on cancer, there's more work that we're doing on how we refine our cancer pathway to understand how we get the right system to deliver the right results for our patients.
Thank you very much. Jenny Rathbone.